All right, we are recording and we're live.
Good evening. My name is Steve Gregg. I'm the Executive Director for the National Association for Continence, and I'd like to welcome you this evening to a really nice presentation. We'll talk a little bit more about our presenter in just a moment. The presentation this evening is learning about male stress urinary incontinence, another one of those topics that many sufferers find challenging to talk to. So we would like to provide you with as much information about the condition, treatment options, and management solutions as possible. I would also like to thank Boston Scientific for helping us generate the content that you're going to see this evening. Next slide, please. These are the challenges that we're going to try to address this evening. Male urinary stress incontinence. Again, it was developed in partnership with the National Association for Continence and Boston Scientific. And our presenter this evening is Dr. Herman Bagga, a physician, and we'll learn a little bit more about him in just a second. Next slide, please. A lot of people don't know who NAFC is. We are the National Association for Continence. We're a 37-year-old nonprofit organization dedicated to improving the lives of those individuals with incontinence, voiding dysfunction, and pelvic floor-related disorders. We are a nonprofit, non-biased, and we're their leading source of public education about the causes, prevention, treatments, and management for incontinence. Next slide, please. Our purpose is to be the leading source for public education for advocacy about managing those conditions related to incontinence, specifically bladder and bowel dysfunction. Our key objective is to destigmatize incontinence and promote preventative measures. We'll hear a little bit about that this evening. We'll motivate individuals to seek treatment and provide collaborative advocacy for those that are affected by this problem. Next slide, please. A little bit about our constituents. These are the people that we deal with. We constantly remind ourselves that we're dealing with those individuals that are challenged by incontinence, whether that is them personally or them as a caregiver. But these are real people with real lives to live, places to go, errands to run, and families to take care of. And so to fulfill our mission, we need to find ways like tonight to create a dialogue with people within the context of their lives and how we can reach them and motivate them to seek help. Next slide, please. We're very fortunate enough this evening to have Dr. Herman Bagga present for us. He was trained at Johns Hopkins School of Medicine. He is extremely well published and well spoken at national conferences. He's led a variety of really high, interesting and significant positions. Particularly, he founded the Center for Men's Health in Pittsburgh. And so without further ado, I'm going to pass this over to Dr. Bagga to present. Dr. Bagga, it's all yours.
Great. Thank you so much, Stephen. I really appreciate it. Thanks for having me. And thanks to y'all for coming to listen about this. This is, of course, a very important problem, just as Stephen had described, and something that a lot of patients I've seen sometimes can be hesitant to talk about, whether because they feel shy about it or because they feel it's normal. That's something they just have to deal with, whether it be due to age or due to other medical comorbidities. They think it's inevitable. And it's certainly not. There are ways to reestablish quality of life when a person is incontinent from many different reasons. So, we're going to talk about incontinence, and we're focusing on stress urinary incontinence, but there are multiple types of incontinence that can occur. Incontinence in general is just bladder leakage. So it's loss of urine. The bladder is intended to hold the urine for you until you're ready to evacuate it from the body. But when it leaks, it can be a big problem. Stress urinary incontinence is when a person can't stop the urine from flowing out of their body, usually during movement. The way I describe it to patients is it's almost like having a leaky faucet. So, you've got it's almost like the valve isn't working properly. So you should be able to close that valve until you're ready to turn open the spigot so you can urinate. But for some folks, that valve just doesn't close all the way or just isn't tight enough. And when that happens, a person can have a constant drip, drip, drip. Some people, it's only when there's enough pressure in the bladder where it pushes it so much that it overwhelms that weakened valve. And that's during activities like when you're moving, so when you're laughing, lifting, bending, sneezing, I hear a lot about, or when you're in a laying position and suddenly stand up, you're moving and then the urine can flow out. And it can be very burdensome. Worldwide, about 500,000 men suffer from stress urinary incontinence, and a lot of females as well. In addition, there is something known as urge urinary incontinence, and that's another type of incontinence. It's not the type of incontinence where you have a leaky faucet where the valve isn't working properly, but rather you have an overactive bladder. So your valve works just fine, but that bladder is so strong and so hyperactive that it'll just squeeze and overwhelm the valve. It's called a valve because I think it's easier to describe. It's actually called the urinary sphincter. And that's when you have urge urinary incontinence. Men with that don't necessarily leak from movement or coughing or sneezing, but rather they get a sensation like they got to go, but it's just too late. And that's the other type of incontinence, also unfortunately very common. So, you can see how common it is because nearly 1 in 20 men in adulthood have some form of incontinence, whether it be urge or stress related. And so it's our job as health providers to help patients sort out which one it is and then find solutions so we can help them out. The urinary process, a little bit of background of how the urinary bladder works. That round structure that's inside the pelvis above that little red area, that is the urinary bladder. And the urinary bladder, it's shown to be very thick here in this diagram, but actually the urinary bladder is a very thin-walled structure, just a few cell layers thick. And what it does is it stretches. And so it's like a balloon. And the urine comes down from the kidneys into this bladder. The bladder stretches, stretches, stretches. When it stretches large enough, it sends a signal up through the spinal cord to the brain and says, hey, it's time to urinate. The brain reconciles whether it's an appropriate time to urinate or not. If it's not, it says don't. If it is, then it says you may proceed. It opens up the valve or the urinary sphincter, and then the bladder is able to squeeze and get all that urine out. The urinary sphincter is labeled down there beneath the prostate. And it's like a donut-like structure that goes around the urethra. So it's literally encircling it, just like a valve would, and it keeps tight. So until it's time to urinate, and then it weakens, it opens up, the bladder squeezes, and then the urine is able to exit out of this tube called the urethra, and you're able to evacuate the bladder. Most men, once they're done urinating, that bladder should have a minimal amount of urine that's left, less than, we say, 50 milliliters or so, indicates a healthy bladder that's able to completely empty. So, causes of stress urinary incontinence. Now, I'll tell you what, let's just take a quick break and I'll just go back for a second. Before we go into stress urinary incontinence too deeply, let me just talk a little bit about urge urinary incontinence, because I'm sure that's going to come up a little bit too. So urge urinary incontinence is when that signaling pathway isn't working. I mentioned when the bladder gets too full and then it's time to urinate, it sends a signal to the brain and the brain reconciles whether it's time to pee or not. Sometimes it doesn't do a good job of that reconciliation. And so it squeezes anyway, and it kind of just starts to shoot the urine out. So you get that urgency, you have to rush to the bathroom. What causes that? It can be caused from anything that causes nerve dysfunction. So anything that could inhibit that signaling going through the spinal cord, multiple sclerosis, Parkinson's disease, severe diabetes, things like that can really affect the nerves that are responsible for the signaling to decide when it's an appropriate time to squeeze the bladder. The other thing is if the bladder itself becomes overactive. So for men, we most often see that. You see there's a diagram of the prostate, and unfortunately, the prostate is often the big offender. The prostate wraps around that urethra like a donut, and it actually kinks off that urethra. When it kinks off that urethra, the pressure in the bladder gets really high. High pressure environment starts to damage the bladder, and then the bladder doesn't know how to function properly. I tell my patients, think of the bladder like a pump. You kink the hose to a pump for long enough, the pump's going to overheat, it's going to malfunction, it's going to start to sputter and have problems. And that's what happens with urge urinary incontinence. The bladder is sputtering, just like a pump would when you kink it. Then it's urgency, frequency, getting up at night, rushing to the bathroom, and eventually when it's dysfunctional enough, leakage of urine. We deal with that by dealing with the primary problem, getting the kink out of the hose. You deal with the prostate blockage or other blockages as necessary. In the case of a nerve issue, you deal with the primary issue, whether it be multiple sclerosis or Parkinson's. And last, you can also provide medications that start to heal or relax the bladder so that it's not so overactive anymore. It's a little whirlwind tour of urge urinary incontinence. I think talking about incontinence in general would not be appropriate without at least talking about urge. But let's get back to stress urinary incontinence. What if the problem is not that the bladder is dysfunctional? The bladder is humming along fine. There's no blockage. There's no kink in the hose, no prostate issues, but rather that sphincter is not functioning properly. So it's just not tight enough. That can happen due to several reasons. One of the main reasons is prostate cancer surgery. Unfortunately, we perform prostate cancer surgery, of course, to cure a man of cancer. But when you're taking that prostate out, you see that red structure right above the sphincter, you're actually pulling and tugging the prostate. And that pulls on the sphincter as well. In addition, there are nerves that wrap around the prostate very intimately or stuck to the prostate itself that you carefully have to dissect off. And they're getting pulled and tugged as well. And so when those nerves get damaged and the valve or the sphincter is particularly pulled or tugged, so it starts to become dysfunctional, you end up with a weakened sphincter. Up to 50% of men will have leakage right after surgery for prostate cancer. Thankfully, for most men with rehabilitation, whether it be with pelvic floor physiotherapy and Kegels exercises or tincture of time, they can eventually have healing of that sphincter. But unfortunately, some men will still have incontinence beyond 1 year. They say up to 9 to 16%. Thankfully, in more recent years, that number is going down as prostate cancer surgery is becoming more and more perfected with the robotic approach, for example. But up to 8% of men in the most recent study still will have incontinence after a year of treatment, and that's a very significant number of men. Also, you can have stress urinary incontinence due to other reasons. Maybe you have a neurologic disorder where the valve itself is not working. Parkinson's is an example of this. Parkinson's can affect the sphincter and its ability to close and open as well. Multiple sclerosis can also work in unpredictable ways and affect that, as can some sort of damage to the spinal cord or the nerves, which you might have with pelvic trauma. Maybe other surgeries like rectal surgery, which affects the nerve system in the pelvis. When you have enlarged prostate surgery, a common one is a transurethral resection of the prostate, a TURP, outstandingly rare, but if someone goes too far and gets some of that sphincter, there's a risk that it could get damaged. Radiation as well can directly affect that sphincter, and it can actually freeze it. So, the sphincter is supposed to be pliable, it's supposed to be able to stretch, open and close, but with radiation, tissues become woody and fibrotic, and they're not able to squeeze quite as well. So that's another potential cause. Stress urinary incontinence causes suffering, and it goes beyond the leakage. It can cause depression. I've had patients come in, they're depressed, they're, not spending time with their family because they're worried of the smell. They don't want to burden people when they go out, having to continuously go to the bathroom or change. They start to isolate themselves. They become emotionally disturbed. It's a big, big problem. And so addressing it is very important. Any man who has those risk factors, I will directly ask them. In fact, even if they don't have those risk factors, it's such an important problem. I ask all men if they have incontinence when they visit my office, regardless of the reason they came. So because prostate cancer, is one of the common causes, this is a little bit more information of what I was alluding to earlier. There are about 70,000 prostate removals each year done for cancer. And this is a little bit of what I was talking about. You see that the bladder on the right side of the screen, and then the prostate right in the middle. That prostate is actually cut out. So that section is removed along with those nerves that are around it have to get pulled and tugged. Sometimes those nerves have to be directly even sheared a little bit to get the cancer out because they could be trying to invade those nerves. Once the prostate is gone, you sew the two ends together, and that stretching to get everything into place can affect the nerves as well as that valve, that sphincter itself, weaken it, and one can end up with incontinence. How do we manage incontinence? So, when you have urge incontinence, which I talked about before, that overactive bladder, we talked about some of the ways that we manage that. But with the stress incontinence, once again, with the leaking like a drip, 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 again, I use that analogy of a leaky faucet. There are a few different ways to start. You can do behavioral modifications. Sometimes you'll reduce fluid intake and plan restroom breaks. I don't like to do the reduced fluid intake, but a lot of patients will do it on their own. They end up dehydrated, which is unfortunate. They try to reduce it before they go out, for example. So hopefully there won't be as much leakage when they leave the home. They plan restroom breaks. Other things that they can do is, they avoid activities where they're moving around a lot, which is unfortunate. Less physical activity can lead to a host of problems like obesity, hypertension, and all the comorbidities that come with not having enough activity. You can also do interventions to tighten up that valve, tighten up that urinary sphincter. That urinary sphincter is a muscle, just like any other muscle. And if you work it out, it gets tighter and it gets stronger. You can do Kegels exercises on your own. A Kegels exercise is, the way I describe it to men is, if you've ever been urinating and someone calls your name and you got to get out of there, those muscles that you tighten to get out of the bathroom when you're still urinating, so maybe when you stop the urinary stream midstream, that's a Kegels exercise. A Kegels exercise is done by tightening up those muscles and holding it tight for several seconds. You count 1, 2, 3. Try to get up to even 10 if you can and hold those muscles, although it's hard to do it for that long. You want to do them in sets of 8 to 10 every few minutes and try to do as many as possible. If you can get up to 100 plus, that's ideal per day. Biofeedback is another way that it can be done. That's often done in conjunction with pelvic floor physiotherapy. And this is where you learn how to tighten up that sphincter, tighten up the pelvic floor, which are the muscles that support the urethral sphincter, kind of like, the friends around it that are helping and hugging the sphincter to help it function better, with the help of a pelvic floor physiotherapist. Just like any muscle intervention, whether you're working out with a personal trainer, this is a personal trainer for your pelvic floor and your urinary sphincter. We usually start with a professional initially. They teach you the exercises, and then once you know what to do, you can continue to do it on your own. There are ways to just cope with it: pads, diapers, catheters, penile clamps. These are all ways to just kind of stop the urine from manifesting itself in the outside. Very difficult, of course. The pads and the diapers, they might absorb, but they have got to be changed. They can cause a smell. Catheters, internal catheters, I hate. They're painful to have in and they cause infection. So I try to avoid those under all circumstances if possible. External catheters are almost like a condom-like device that goes on the outside of the penis. It sticks to the penis, and then it's not on the inside, so it's less uncomfortable, but burdensome nonetheless, because what if it peels off with activity? Penile clamps are as unfortunate as they appear, in that they're clips that go on there. Some of them can be very uncomfortable, but there are ones that can be more comfortable, several brands that are out there, and a lot of clever patients that have actually made their own and actually sell them on places like Amazon and things like that. And they creatively pad them so they work a little bit better. And those can be a coping mechanism used, temporarily when you go out, or maybe during the day when you're gardening or doing something with more activity. Coping solutions can work in the short term, but they can be expensive, and they're a nuisance as well, and can be problematic for some of the other reasons I talked about. You just look at that cost in the 5 pads per day for 5 years. I mean, that can really add up over time. Not to mention the fact that it's not really a great solution to begin with for many men. Long-term solutions, outside of those behaviorals, there are surgical therapies that we can do for urinary incontinence. There's a male sling system. So the sling is where a tiny piece of mesh is used to move the urethra to the appropriate location, so that your natural sphincter, although it's weakened, can actually work a little bit better. So what happens is that urethra is kind of dangling down. We bring it up closer to the sphincter, closer to where those Those pelvic floor muscles support that urinary sphincter, and that sphincter just has a little bit more of we call it purchase sometimes, but a little bit more of a trajectory, so it can be more efficacious when it does tighten up and prevent some of the leakage. That's a great procedure for people who have mild incontinence, maybe 1 to 2 pads per day, and they can often experience complete resolution and can have incontinence basically right immediately after the procedure. However, it's not the sling, it's not the mesh that actually does the work. It's the scar tissue that develops there, and it actually tightens the urethra into place. So the sling just brings it to the right location, and then your body does the rest of the work over the next 6 weeks. It creates this hammock, basically, of scar that holds it in that location. It's important to note this is very different than a sling that's used for females. Slings for females can be very effective, but many may know they are recent times where they're quite controversial to be used due to some of the complications. And they work in a different way fundamentally from male urethral slings. The female slings have been perfected, and now they're kind of they're working a lot better with less complication rates, but male slings never had that issue in the first place. Very low complication rates. So like I said, over here, it acts like a bit of a hammock where it supports the urethra and it allows that natural sphincter to work a little bit better. It's a quick procedure, by the way, in case anyone is wondering. More time to talk if anyone has more questions about it. But, as a surgeon, I find this stuff fascinating. It's a quick procedure, rarely takes more than about 35 to 40 minutes, and people go home the same day. So just a few tiny incisions that are made, dissect where you need to go, put that sling, and people can move on with their lives. The artificial urinary sphincter is the other way. So, if the problem with stress urinary incontinence is that the sphincter or the valve isn't working, why not just replace it with a brand new valve? And that's exactly what this procedure does. It's considered the gold standard of treatment because it works for men of varying amounts of urinary incontinence, whether it be a small amount of a couple pads per day or a larger amount of 5, 6, 7 or continuous urinary incontinence. The artificial urinary sphincter can work quite well for those men. It mimics a healthy sphincter where it wraps around the urethra. And I'll show some photos here, but it actually wraps around the urethra. The way I describe it to people is that it actually kind of looks like, the floaties the kids wear when they're swimming, those little, 3 little balloons that go around their arms when they're swimming around. Think of something like that miniaturized into a tiny cuff that's the size of the end of my pinky. That cuff gets wrapped around the urethra on the inside of the body, and it always stays full of fluid. So those 3 little pillows are always tightening. They're full of fluid, and they kink off that urethra. There's a small pump that's inside the scrotum. That's all inside the body. No one can see anything. You do 2 pumps inside the scrotum. No one knows it's there except for the patient. They find it, pump it twice, and that signals the valve, artificial urinary sphincter, to open. And it stays open for a period of 2 minutes. During that 2 minutes, a man can empty his bladder, make sure everything comes out, and then it automatically closes right back up again, and they can go about their day. Again, a quick outpatient procedure, small incisions, usually, a 2 centimeter incision is made. This one takes a little bit longer, maybe an hour and 15 minutes or so, but folks will go home the same day as well. We don't start the device right away, though. We wait 6 weeks. It would be a little bit of swelling. It would be uncomfortable for a man to find that pump in the scrotum right after the procedure because of the swelling and a bit of the discomfort. So we wait 4 to 6 weeks, let the inflammation go away, let it heal, and then a patient comes back and they teach them how to use the device. Most men are quite satisfied with it. It tends to work quite well. And I usually tell men that, it's a great solution, doesn't last forever, just like anything else, artificial hip, artificial knee. It's got a lifespan on it, usually about 10 years or so. But that 10 years is a time period where you can really experience an improved quality of life. And if and when it breaks down, you can just put another one in. It's just as quick as the original procedure. Insurance coverage varies for all of these different forms of stress urinary incontinence treatment. Unfortunately, coverages are pretty weak for some of the barrier protections, like the pads and the, and the clamps and things like that. But it does tend to work pretty well for the sling and the sphincter, probably because they perceive them as more permanent and less expensive overall options, generally covered by insurance, and it works quite well for a lot of patients. So, this is just a few men talking about it. So benefits of stress urinary incontinence products, of course, you gain continence, urinate when you want, you have your back in control, and there's high patient satisfaction. Everything got its risks. This is a question that comes up quite often, so we threw the slide in there. Surgery always, of course, always sounds scary. Surgery inherently always has some risks. Infections, damage to adjacent structures, bleeding, all of these are possibilities, although I'll tell you very frankly, that's outstandingly rare in the hands of someone who does this very frequently. As long as there's someone who does the surgery with a lot of frequency, it becomes routine, just like anything else would, and complications become outstandingly rare. Some things can't be avoided. For example, the fact that the device has a lifespan on it for about 10 years, and that the device was chosen appropriately. If you use a sling, but you tighten it way too much, well, then it could make a hole in the urethra. That's no good. Same thing with an artificial urinary sphincter. If it's too tight, it can erode a hole through. And so this is where the art of medicine or the art of surgery comes in, where, your provider and you have to consider the nature of the incontinence, what the burden is like, and then appropriately choose the right device and place it in the appropriate way. Nothing is one size fits all. So this is a little bit of a summary about stress urinary incontinence. Of course, we talked about urge urinary incontinence as well. This is focused on stress urinary incontinence for this talk, of course. But as we're going to leave plenty of time for questions, which is what I really love to do, and I can go over those as well. So any questions about either would be great. I highly encourage you to visit nafc.org. You can hear a lot of information about urinary incontinence, both the urge and the stress variety. All right, so with that, I'm going to pass it back to you, Stephen.
Great, thank you, Dr. Bagga. We have had a number of questions come through, some of which you may be able to answer. The first question was, could you talk a little teeny bit more about the internal versus the external sphincter? I think you covered that very quickly.
Oh, yeah. So the internal, do you mean as a therapy or as the actual anatomy? I think they're talking about the anatomy, which I didn't talk about quite so much, and you can post another question if that's not the case. But men have considered to have two urinary sphincters. There's the internal urinary sphincter and the external urinary sphincter. The external urinary sphincter is the one that provides the majority of incontinence for men. It's made of skeletal muscle. It's the one that sits right beneath the prostate like a donut, and it's that predominant valve that's controlled and keeps a man from leaking. Because that's the sphincter that often gets damaged with prostate surgery, and that's the one that's heavily innervated by those pelvic nerves, which can be affected by some of the things we talked about. It's the one that's usually the main suspect when a man has continuous stress urinary incontinence. The internal sphincter is actually the bladder neck. So as the bladder, which is a round organ, funnels down into the urethra, right at the end of that funnel, that area is called the bladder neck. That's not skeletal muscle, but something we call smooth muscle. It's under involuntary control, meaning it's automatically managed and a person has no control over it on their own. But it acts due to internal signaling as to when the bladder is full or not full, and it actually squeezes. So that funnel will tighten itself up and will slow down the flow of urine so the external sphincter can do the rest of the work. The internal sphincter can actually get affected by procedures such as TURPs or transurethral resections of the prostate. And so, urologists have to be very careful that if a person already has problems with their external sphincter, they cannot affect that internal sphincter because it's their last line of defense. If that makes any sense. But hopefully that's what you are going for. As a procedure, the internal sphincter, of course, is that artificial urinary sphincter that I talked about because it's on the inside, no one can see it. And the external sphincter would probably be devices like the clamps and things like that, commonly called a Cunningham clamp, that pins on the outside of the penis to keep it closed.
I think that's great. I think very oftentimes those individuals are challenged with trying to understand all of the nuances of what you know automatically when they're talking to their physician about treatment options. So it's probably worthy for all of us to think about how much education we can provide without overwhelming those that are either about to go into a physician or coming out of talking to a physician, like what did he say? So I think that's great. The other question, and it's a question that we see a lot at NAFC, is, I've had surgery for prostate cancer, and now I've gone a period of time, and you address this very nicely, 6 months, 12 months, but I'm still leaking. And then the question is, am I going to leak the rest of my life, and or what can I do about this? You mentioned physical therapy, pelvic floor physical therapists. We love them because they can also provide both education and then nuance to get back to the right position. Could you speak a little bit about that?
Absolutely. So, two parts to this question. The first is the time course, which is very interesting and important to note. In the literature or the research studies, we often use 24 months as a cutoff. So if a man is going to find improvement, it's usually going to be during that first 2 years. If you cross that 2-year threshold, it's unlikely that a man is going to improve any further. But of course, like everything I said before, one size doesn't fit all. It also has to do with the amount of effort that was put in. Was enough effort put in during that first 24 months to even say that, a person even tried or went through the exercises or worked with a pelvic floor physiotherapist in an appropriate way? The newer data is saying for those who are motivated and working hard, that the 12-month mark can be utilized, and sometimes even the 6-month mark. If a man comes in and has been working really hard, doing the Kegels exercises appropriately, consistently, and they've worked with a pelvic floor physiotherapist, and they're still having leakage at 6 months, I'll actually go ahead and do a procedure right then, because they've done so much that, in my experience of having seen so many of these patients, it's more about effort than it is about time. And the point about pelvic floor physiotherapy is so important, Stephen. Pelvic floor physiotherapists are just awesome. They are so good at what they do. They take a very detailed history. They help to identify even behavioral ways to manage things because they get a sense of when the leakage occurs. And most importantly, however, they teach a man how to tighten those muscles up. So, there are options such as biofeedback, where a man turns to learn about themselves and help to identify those muscles a little bit better. Most men aren't even aware of the pelvic floor muscles because we rarely have to tighten them up. And so you have to use analogies like I did before about going to the bathroom and stopping midstream to help even identify where they are. So the pelvic floor physiotherapist can identify ways for men to work on that and improve on their own, first their guidance and then on their own. Another very important thing about pelvic floor physiotherapists is for urge urinary incontinence. So urge urinary incontinence, I'm just going to take a step back from what we've been talking about, again, is when that bladder is overactive. It's squeezing when it's not supposed to squeeze, and it's overwhelming the valve. That can occur due to a high pressure environment in the bladder over time. Maybe a man had a tight prostate or a tight pelvic floor muscle for an extended period of time. And I'm seeing this so often. Doctors, nurses, busy professionals, we're holding our urine. We're not going to the bathroom on time. It's time to go. We squeeze, we push, we get out of the bathroom until we get back to work. What we're doing is we're tightening up those muscles so tight that they're kinking the hose. They're kinking the urethra, putting pressure on the bladder, and then that bladder is starting to malfunction. So there's a huge role for pelvic floor physiotherapy to do the opposite, to relax those muscles, open them up, unkink the urethra so the bladder can have less pressure in it, it can heal, and then you'll actually have less urge incontinence as well. So, going both ways, they can be utilized in multiple ways to manage urinary issues.
Yeah, that's terrific. We hear a lot about physical therapists talking about it's not always strengthening, to your point. It's sometimes relaxing or loosening. The other piece that we didn't know at NAFC years ago was a physician told us that most of us are never told how to void correctly. And by that, we were told it would be best, particularly if you're at home, when you go into the bathroom, is to sit down, yes, men and women, to void, and then stand up, and then sit back down and try to void again. And in that way, you empty your bladder completely, which also helps a little bit of the relaxation you were talking about. Do you often advise your patients with something similar?
Absolutely. So, that can be very important. There are two behavioral modifications that I discuss quite often about how to void, learning the proper way. And those are utilized in, a therapy called bladder retraining. So training the bladder to empty and to squeeze at appropriate times. The first one is called double voiding, which is exactly what you were talking about. You urinate, you don't push or strain. You never want to push or strain because then you're tightening up those muscles and creating additional irritation and dysfunction in that bladder. But you give yourself a chance. Sitting is one of the best ways to do that because you're not pushing, you're not straining, you're just sitting down, you're in a relaxed state. Opens up those pelvic floor muscles as well so that the urine can drain. And then you get up. You do whatever you have to do. Maybe I clean my glasses, someone else might fix their beard or whatever it might be. And then they go back to the bathroom after a minute or so, go back to the toilet after a minute or so and sit right back down again. And this time, again, don't strain, just give yourself a second chance. That's called double voiding. It's great because it empties the bladder completely. And then there's not urine that's festering in the bladder, causing additional dysfunction. Timed voids is the second one. Timed voids is when you go to the bathroom every 3 hours around the clock. So regardless of whether you feel a sensation or not, you go to the bathroom. That's important because as men start to have worsening urinary issues, their nerves just get used to it. So they say, all right, well, this is just how it is. And they start to not to respond to having full bladders. And the bladder stretches and stretches over time, which is very unhealthy for the bladder and potentially even in the kidney in the future. So you want to do timed voids to kind of teach that bladder to kind of empty at appropriate intervals. Importantly, you do these just during the day, not at nighttime. You don't have to set up an alarm all night, of course.
That's terrific. We've had a question which is somewhat new to us. Maybe you can address it. A gentleman that suggested that he's been diagnosed with what's called latch incontinence. He seems normally fine. When he gets home, he puts the key in the door to come in the house. Then he's overwhelmed with urge to void. Do you know anything about that and what some of the treatment options might be for something like that?
Yeah, so that's something we hear about. It's a learned behavior. So latch incontinence, some people call it doorknob incontinence, doorstep incontinence. So when you reach that area where you're used to urinating and you get those triggers, you kind of feel like you have to go to the bathroom right away. One way, of course, is to avoid those triggers entirely. Of course, we don't want everyone crawling through the window to get home. But there are other ways are to urinate before you reach the house. So, if you know that you always are triggered when you get to the house and you start to open the door, just try to urinate before your trip and see if you can empty the bladder so the bladder learns that, that's not the trigger. The other thing is to not allow triggers to couple on themselves. So other commonly known triggers for, that make the bladder malfunction are foods and drinks. So anything, my list that I always tell, this list was compiled by patients for me. I tell my other patients, coffee, soda, tea, alcohol, any carbonated beverage, even, sparkling water, club soda, things like that, chocolate and other cocoa products. Strawberries, for whatever strange reason, has come up a lot. But I trust my patients. I've heard it from many. That's another potential trigger. Very spicy foods, very acidic foods. So heavily tomato-based foods, for example, can also be triggers. All of these seem to cause a little bit of irritation to the urinary bladder. And so, getting back to the point, you kind of avoid those foods and drinks right before you come home, especially the drinks are a little bit more easy to avoid.
That's terrific. So we've had a couple questions. I think this is one of the things that a lot of patients struggle with, and I'm interested in your opinion, is we know that a lot of men and women oftentimes will go in and talk to their doctor first about either SUI or urge-related incontinence. And so they're talking to primary care. And many of the primary care doctors, as you know, are not as well versed as someone like yourself, nor do they typically have enough time. And so then patients struggle to find highly qualified urologists that either do surgery on a frequent basis or have a lot of expertise in this space. How do you recommend that patients find a good urologist?
So, it's always a tough one. And I always say you just ask, right? I think a lot of patients feel hesitant to ask a question to their physician that could be maybe interpreted in any sort of negative way. They don't want to say, well, how many of these surgeries have you done? Because they worry that that surgeon might feel offended or somehow being told that they're not adequate. And I'll tell you, nothing could be further from the truth. I would say there's no doctor who seriously takes their oath that would not appreciate that question and honestly tell you, you know what, I don't do this a lot, but I know someone who does. Because all of our goal as a collective, as a collective profession is to get you to the right person. And I'll tell you, the trend within urology is quickly becoming little centers of excellence, even individuals of excellence, where certain individuals may do a lot of incontinence work, another person may do a lot of cancer work, infertility work, things like that. And I think we're more than happy to kind of ensure that we get you to the right person. So my advice would be just ask. You can ask your primary care doctor. Don't be afraid to say, hey, I need some more help. I know you've tried your best, but do you know anyone that does this all the time? And if you see the urologist, then say, hey, listen, thanks for giving me the background. Is this a surgery you do a lot of? Those are the right questions to be asking.
Yeah, we do a great deal. We have a Center of Excellence program. NAFC has founded a Center of Excellence program based on some really qualified physicians, as well as a physician finder that we try to get patients into the right kind of physicians. And we can't always do that, but then we have great relationships across, the societies, OGS, or the American Urological Association. And we can typically help people get to somebody qualified, contacting you and saying, we have this question. We struggle a little bit, like most of America. If you get to rural or isolated regions, it gets a little tougher. Pittsburgh, Baltimore, Philadelphia, not so hard, but we're often there to help. Let's see if we have anything sort of new. I think you've addressed Kegels, how to find Kegels, how to find physiotherapists that are qualified in this space.
I would say for physiotherapists, the main question you want to ask is, how often do you take care of men? Pelvic floor physiotherapy was often dominated, taking care of women only, mainly because after childbirth, there can be a lot of weakening of the pelvic floors. And so working on biofeedback and Kegels to tighten up that pelvic floor was a very important task. It's becoming more common with education, folks like the NASC getting the word out that men are also seeking care. And so, it's good to find a pelvic floor physiotherapist that is well versed in both, because it's very different anatomy.
No, I think that's a really good point. The American Physiotherapy Association, APTA, is the Association of All Physical Therapists. There are about 90,000 physical therapists, but a subset of that in their physician locator is for pelvic floor specialists. And there are about 3,500 of those across the country. So if you're looking for one, that's a really good place to start. But I think the question about do you treat men is really a critical and a really good question that should be asked. Well, excuse me, Dr. Bagga, this has been absolutely fantastic. I hope the group has enjoyed it. Certainly, if you're listening or engaged tonight, you can visit our website and, pardon me, and look for more information. We have men's conditions that cover a wide range of things. And we also have a Ask the Doc section, which oftentimes we can address certain questions. We are not allowed legally to provide medical advice, like Dr. Bagga may be qualified, but we can typically find a way that you can find somebody who can address your question.
Excellent. Thank you so much, Stephen. Thank you to the organization, and of course to the NAFC, and of course Boston Scientific for helping to sponsor this. Thank you all for listening, and please help get the word out and make sure that your friends and your family and your colleagues are also empowered to ask these sorts of questions so they get properly taken care of. So again, thank you so much. I'm Herman Bagga. I'm of course in Atlanta, Georgia, but if you're outside of Georgia, then please check out like the physician finder that Stephen brought up. You'll find a lot of great qualified individuals to help you out.
Thank you very much and have a great evening.
Take care.